Today my lecture will be devoted to pleural and lung diseases. First, I will start from pleural diseases. Pneumothorax. Pneumothorax, air or gas in the pleural space, pneumothorax, may originate from rupture of the respiratory system, esophagus or chest wall, or it may be generated by microorganisms in the pleural space. Pneumothorax may be classified as spontaneous, traumatic, or iatrogenic, depending on the cause. It is referred to as closed when the chest wall is intact, or open when a breach in the chest wall exists. The magnitude of pneumothorax is expressed as an estimate of the percentage of collapse of the lung. Since the pleural space is a cone-shaped cage, a small rim of air may represent a 10–15% pneumothorax and relatively minimal compression of the lung, a 50% of pneumothorax. The volume loss decreasing from lateral to medial. When the visceral and parietal pleures are not adherent, pressure in the pleural space may be sufficient to displace the mediastinum to the opposite side, tension pneumothorax. Both open sucking chest wounds and tension pneumothorax are surgical emergencies since the seriously compromised ventilation and because of shift in the mediastinum after venous return. In trauma patients, pneumothorax is often associated with blood in the pleural space, hemopneumothorax. With esophageal rupture, the combination of pleural suppuration and air is known as pneumothorax. Clinical findings. Essential in diagnosis include chest pain referred to the shoulder or arm of the involved side, dyspnea, hyperresonance, decreased chest wall motion, decreased breath sounds and voice sound on the involved side. Mediastinal shift away from the involved side on the case in the case of tension pneumothorax, and chest X-ray revealing retraction of the lung from the parietal pleura. Iatrogenic pneumothorax may occur as a result of underwent introduction of air into the pleural space, puncture or rupture of the lung, or intentional introduction of air into the pleural space or mediastinum. Procedures often complicated by pneumothorax are thoracentesis, placement of a percutaneous vein catheter, subclavian internal jugular for central venous pressure monitoring or hyperalimentation, operation on the chest wall, neck, back, or upper abdomen, lung or pleural biopsy, brachial plexus block, arteriography, and intercostal nerve block. An underwent rupture of the lung may occur with assisted ventilation for anesthesia or respiratory support. Pneumothorax may intentionally be induced for diagnosis or treatment. Spontaneous pneumothorax may occur in any groups by most common in males 15–35 years old of age. A high incidence is reported in patients with Marfan syndrome. In newborn infants, spontaneous pneumothorax may be asymptomatic and discovered as an incidental findings on a chest X-ray, or it may cause respiratory distress. In young adults, spontaneous pneumothorax develops without known cause in localized emphysematous bleeds near the apex of the upper lobe or along the superior segment of the lower lobe. In elderly patients, generalized emphysema, bullous emphysema, or some other predisposing cause is usual. The left and right sides are involved with approximately equal frequency. Bilateral involvement and tension pneumothorax are both uncommon. Males predominate over females 10 to 1. An associated effusion that may contain blood is present in 10% of cases. About 30% of patients with spontaneous pneumothorax have chronic pulmonary disease, usually consisting of chronic bronchitis or emphysema. A history of smoking, pneumonia, recent upper respiratory infection, or asthma is often obtained. Secondary spontaneous pneumothorax related to active disease, may occur in staphylococcal pneumonia, lung abscess, or a multitude of other less common pulmonary conditions, including sarcoidosis, endometriosis, and bronchogenic carcinoma. Critical to definitive treatment is the nature of the pneumothorax. In the case of simple pneumothorax, if air only is introduced into the chest space and no dyspnea is noted, observation and symptomatic therapy are indicated. If simple pneumothorax is secondary to laceration of the lung from iatrogenic cause or rupture of blood disease, the severity of symptoms, chest pain, shortness of breath, nausea, vomiting, syncope, and shock, is evaluated to define the need for drainage. Physical findings may include diminished ventilation of the affected lung and hyperresonance, but diagnosis may elude the examiner in minimal pneumothorax unless a chest X-ray is obtained. If the size of the pneumothorax increases in patients who is being observed, a thoracostomy tube must be placed. Tension pneumothorax may produce mediastinal shifts and tracheal displacement away from the affected site, with neck vein distension, cyanosis, and shock due to obstruction of venous return. X-ray findings show the extent of pneumothorax. The main disorders that must be differentiated from tension pneumothorax are cardiac tamponade and acute congestive heart failure. The physical findings of tension pneumothorax are occasionally obscure, and the condition in such cases is first suspected only with a chest X-ray. The X-ray appearance of a giant lung cyst is similar to that of a distended stomach within the thorax after rupture of the diaphragm and should be differentiation. Placement of a nasogastric tube in the latter condition may be diagnostic. Treatment of pneumothorax involves re-expansion of the involved lung. With a simple, stable pneumothorax of minimal amount, reabsorption of air will achieve re-expansion. Occasionally, thoracentesis is used for diagnosis and rarely for re-expansion, as continuous observation for possible recurrence is necessary. Closed tube drainage is the most reliable treatment. The tube is inserted anteriorly via the second intercostal space into the apex of the pleural cavity. Air leaks that persist for 5-7 days and recurrent pneumothorax are usually treated by thoracotomy. The apical blocks are excised and pleural symphysis is achieved through pleural scarification, pleurectomy, or the use of pleural irritants. Prognosis. The prognosis is properly managed. Patient with primary spontaneous pneumothorax is excellent. In patients with spontaneous pneumothorax, secondary to another condition, the prognosis is determined by the underlying disease. Pleural effusion. With pleural effusion, physical findings may be normal when there is less than 300 milliliter of fluid in the pleural space. Generally, more than 1000 milliliter of pleural fluid is required to cause a contralateral mediastinal sheath. When contralateral mediastinal sheath does not occur with a critical volume of fluid presence, the cause may be carcinoma of the main stem bronchus with atelectasis of the ipsilateral lung, fixed mediastinum due to neoplastic lymph node, malignant mesothelioma, or pronounced infiltration of the ipsilateral lung, usually with tumor. Respiratory movement may lack on the affected side. Fullness or even bulging may occur, and with long-standing effusion, there may be contraction and immobility of the involved hemithorax. The intercostal spaces are narrowed and the ribs have a shingled relationship. Acute inflammation of the pleura may be associated with tenderness of the intercostal space or, in advanced cases, with swelling, redness, and local warmth. Tactile fremitus is diminished with effusion, and there is dullness to percussion. Breath sounds may be exaggerated, bronchial or amphoric in quality over a lung compressed by pleural effusion. The term pleural effusion denotes endogenous fluid in the pleural space. A more exact terminology is used when the character of the fluid is known. Hydrothorax denotes serous effusion, either transudat or exudat. Pyotorax, empyema, hemothorax, and helothorax are other categories. Pleural effusion may occur with disease of the lung, mediastinum, or chest wall. Identification of the specific type of effusion often depends on examination of fluids obtained by thoracentesis. If this procedure is unsuccessful, either needle or open pleural biopsy must be considered. Abnormal amount of pleural fluids accumulate when there is increased hydrostatic pressure, congestive heart failure, decreased colloidal osmotic pressure, increased capillary permeability, pneumonia, increased intrapleural negative pressure, atelectasis, and decreased lymphatic drainage, mediastinal carcinomatosis. Blood may be directly enter the pleural space with trauma, vascular injury, tumor erosion of vessels, and child may accumulate with rupture of the thoracic duct or disruption of mediastinal parietal pleura with its lymphatics. Examination of centrifuge sediment may show tumor cells, bacteria, fungi, tubercle, bacilli, amoebas, or other pathogenic organisms. Pleural effusion from non-pulmonary diseases. Immunologic diseases. Systemic lupus erythematosus is associated with pleural effusion in about half of cases. Isolated pleural involvement occurs in only 10% of these cases. Effusions are usually small. In about 30–50% of cases, the heart is enlarged on X-ray. Pleural effusion may occur with rheumatoid arthritis, usually in middle-aged men. The effusions are usually unilateral and involve the right side somewhat more often than the left. There appears to be no relationship between the pulmonary manifestation or rheumatoid disease and pleural effusion. Cardiovascular diseases. Pleural effusion is seen in constrictive pericarditis and congestive heart failure. The right hemithorax alone is the most often affected, so the effusion may be bilateral. Fluid occasionally localized in interlobal fissure, simulating mass lesions that may spontaneously resolve, known as phantom tumors or disappearing tumors. When this fluid is hemorrhagic, the possibility of concomitant pulmonary infection should be considered. Interlobar effusion involves the right horizontal fissure in most cases, but may be bilateral. Pancreatitis. Pleural effusion secondary to pancreatitis usually affects only left side. The diagnosis is confirmed by findings an amylase concentration in the fluid substantially above that in the serum. Cirrhosis of the liver. Right-sided hydrothorax occurs in about 5% patients with cirrhosis and ascites. Renal disease. Hydronephrosis, nephrotic syndrome, and acute glomerulonephritis are sometimes associated with hydrothorax. Malignant pleural effusion. About half of all patients with carcinoma of the breast or lung develop pleural effusion during the course of their disease, and 25% of all effusions are the result of cancer. Cytologic examination of pleural fluid is positive in 70% and pleural biopsy in 80% of malignant effusions. About 10% of malignant effusions are due to pleural mesotheliomas and the rest to metastatic tumors. About half of bilateral effusions associated with normal heart size are due to cancer, and these are almost invariably associated with hepatic metastasis. Multiple methods have been used to treat malignant pleural effusion. The usual objective is full lung expansion and pleural symphysis so that effusion doesn't recur. The most commonly used regimes are closed tube drainage for 4-7 days with or without installation of a sclerosing agent such as tetracycline into the pleural space. Chemical pleurodesis is successful in 50-70% of cases, and operative pleurodesis is successful in 95% of cases. Operative intervention is avoided if possible in this patient. Thoracentesis or tube drainage may be complicated by pneumothorax, fever, fluid loculation, and infection. Early tube drainage avoids the problem of loculations produced by multiple attempts at needle aspiration. Recurrence of effusion is inevitable after needle aspiration alone, but occurs in only 15% of patients treated with tube drainage. The average duration of life in patients with malignant effusion due to solid tumors is approximately 6 months, and with lymphomas approximately 16 months. This is all pleural effusion. Empyema. Empyema denotes an infected effusive process within the pleural space. Findings may mimic simple pleural effusion. More commonly, there is chest pain, hemoptysis, shortness of breath, weakness with fever, and in several cases, toxemia. The effusion is an exudate. Empyema thoracis thus represents an acute or chronic suppurative pleural exudate and may be caused by multiple organisms including pneumococci, streptococci, staphylococci, bacteroids, Escherichia coli, Proteus vulgaris, tubercle bacilli, fungi, and amebas. Such infection extend into the pleural space in the following ways. First, directly from pneumonic infiltrate. Second, by lymphatic spread from neighboring infections of the lung, mediastinum, chest wall, or diaphragm. Third one, by hematogenous spread from a remote infection. Fourth, by direct inoculation by penetrating trauma, surgical incision, or attempted percutaneous needle or tube drainage of a pulmonary abscess. Fifth, from ruptured thoracic viscera or displaced abdominal viscera. Sixth, by extension of subdiaphragmatic process such as subdiaphragmatic abscess, hepatic abscess, or perinephric abscess. Clinical findings. Signs and symptoms include chest pain, shortness of breath, fever, weakness, and hemoptysis. Also, some patients are severely systematically toxic or even comatose. They may be cyanotic, hypotensive, dehydrated, and oliguric. Temperature may reach 40.6 degrees. Respiration may be grunting, and physical findings of pleural effusion are common. In the absence of fever, empyema must be differentiated from pulmonary embolus with effusion. Laboratory findings include hematocrit in the low third, particularly after rehydration, and a white blood cell count in the range of 14,000 up to 18,000, with a shift to the left. Staphylococcus aureus is the most common organism in all age groups, accounting for over 90% of cases in infants and children. It may lead to the formation of pneumatocells, which are thin-walled cystic spaces that form as a result of a checked valve type of obstruction of small bronchi. This type of pneumatocelli must be differentiated from the benign hernia of the chest wall of the same name and unrelated condition. Pneumatocelli are commonly found in Staphylococcus pneumoniae. Staphylococcal abscess may also occur. Both pneumatocelli and abscesses may overexpand and rupture, leading to empyema formation. Empyema due to Streptococcus pyogenes commonly follows streptococcal pneumonia. It is characterized by thick green that tends to become loculated within 2 or 3 days. The empyema results from extension to a sympathetic effusion rather than from rupture of an abscess. Streptococcal organism can often be diagnosed by sputum, but throat culture is negative about 80%. Causes and blood culture are rarely positive. The diagnosis is best made by culture of the pleural effusion. X-ray findings in all cases involve opacalcification of a portion of the pleural space, sometimes with a fluid level. A pneumonic infiltrate is usually present but may be obscured by the effusion. Complication. The complication of emphysema are emphysema necessitatis invasion of the chest wall, bronchopleural fistula, pericardial extension, mediastinal abscess, osteomyelitis of ribs or cartilage, septicemia, and chronicity. Formation of the bronchial fistula into an emphysema requires emergency treatment to avoid flooding of the opposite lung with pus and subsequent fatal pneumonia. Metastatic abscesses, particularly to the brain, are unusual when antibiotic coverage is adequate. Prolonged suppuration, such as may occur in post-pneumonectomy emphysema, can result in amyloid deposition, particularly in the liver and kidney. Treatment. Therapy of pyogenic emphysema involves use of an antibiotics, drainage of the pleural space, and rarely more extensive surgical drainage. Aspiration will accomplish drainage of the pleural space in a small percentage of patients when pleural effusion is minimal and watery, and a prompt response to antibiotic therapy is expected. However, even in favorable cases such as streptococcal emphysema in young men, hospitalization time is almost 2 weeks longer when needle aspiration rather than closed tube drainage is used. In general, inadequate early drainage is the most frequent cause of subsequent therapeutic intractability secondary to loculations. Prompt underwater seal closed tube drainage of the pleural space is preferred in most cases that don't respond to simple drainage or where rentgenographic demonstration of multiple air fluid levels indicates that loculation has already occurred. When emphysema is associated with parenchymal necrosis or lung trapping, the pleural space may not be obliterated by the above measures, and the residual space may require prolonged drainage to prevent sealing of and reactivation of the infection. By 5-7 days, the space communicating with the chest tube is usually isolated from the remaining pleural space, and the underwater seal is no longer necessary to prevent lung collapse. At this point, the chest tube can be cut, leaving a portion protruding from the chest wall to maintain a chronic draining tract. Later, if the space does not seem to be decreasing in size, or if debridement is required, it can be managed by a larger chest wall and rib resection, known as a Lozier flap. This procedure consists of suturing a flap or skin to the pleura, creating an epithelium sinus into the emphysema cavity for simpler long-term care, more aggressive surgical measure, and reserved for unusual cases. Thoracoplasty, which involves collapsing a chest wall to obliterate pleural space, is rarely indicated. Primary pleural tumors. Two types of primary pleural tumors have been identified: localized mesothelioma and diffuse malignant mesothelioma. Localized mesothelioma most often arises from the visceral pleura, may be either pedunculated or sessile and may either protrude into the pleural cavity or be embedded within the lung. It may achieve a gigantic size. Microscopically, this tumor is composed mainly of spindle cells and appears quite malignant, but usually the tumor is well encapsulated. Local excision is a treatment of the choice, since only about 30% of solitary mesotheliomas are malignant. Pleural effusion is present in 10–15% of cases. The presence of blood in the effusion does not indicate incurability. The rentgenographic finding consists of a peripheral, well-demarcated mass, often forming an obtuse angle with the chest wall. Bone and joint pain, swelling, and arthritis have been described in as many as 2/3 of localized mesotheliomas. Recurrence is often heralded by return of arthritis symptoms and may be benign or malignant. Malignant tumors have a poor prognosis. Most patients die within 2 years. Diffuse mesothelioma may arise anywhere within the pleura. From mesothelial cell origin, it may rapidly proliferate along the pleural surface to encase the lung. Pleural effusion is almost always present and is usually bloody. In cases without effusion, this lesion may present as diffuse pleural thickening. There is little evidence, but these lesions arise from originally benign localized mesothelioma. Diffuse mesotheliomas occur in all age groups but are often seen in relatively young patients, especially men between 40–50 years old. Development of mesothelioma has been directly linked to previous exposure to certain mineral elements used in commercial asbestos products. These elements include crocodylite, tremolite, and most pervasively chrysotil. The mean interval between first exposure to chrysotil and manifestation of disease is about 40 years. Patients complain of pleural pain, malaise, weight loss, weakness, anemia, fever, irritative cough, or dyspnea. The physical findings are those of pleural thickening or effusion. Treatment of diffuse mesothelioma is rarely surgical but consists principally of relief of symptoms and management of the pleural effusion, which may. Radioactive isotopes occasionally provide long-term remissions. The use of chemotherapeutic regimens containing doxorubicin, adriamycin appears to prolong survival of patients with epithelial type tumors. Lung abscess. General considerations. Lung abscess may result from a number of causes, the most common of which is aspiration with subsequent pneumonia, 50%. Bronchial obstruction due to any cause may result in infection behind the obstruction and abscess formation. Approximately 20% of cases of necrotizing pneumonia will result in abscesses. Parenchymal lesions, such as cyst or bull, can be secondarily infected, resulting in abscess formation. Extension of infection from the subdiaphragmatic spaces or liver, post-embolic pneumonia, or post-traumatic abscesses can also cause lung abscess. The cause of lung abscess often determines its location. In abscess secondary to aspiration, the patient position at the time of aspiration is important. When the patient is supine, there is a tendency for aspirated material to enter the posterior segment of the right upper lobe or the superior segment of the right lower lobe. Carcinomatous abscess more frequently involves the anterior segments of the upper lobes. Embolic abscesses are often small and multiple and tend to involve the lower lobes. Basilar abscesses often occur secondary to. Certain predisposing factors to abscess formation have been identified, including a history of alcoholism, debilitation secondary to carcinoma, or chronic disease. Aspiration can follow anesthesia and surgery or may be associated with some predisposing process such as hiatal hernia, carcinoma of the esophagus, achalasia, or tracheoesophageal fistula. Diabetes, pre-existing lung disease, dental caries, and epilepsy are all often predisposing factors. Pulmonary infarcts may become infected in patients with septic bacterial endocarditis or in drug addicts through use of an intravenous apparatus. It should be noted that lung abscesses following emboli are often near surface and bronchopleural fistulas and emphysema may result in the clinical findings, symptoms and signs. The predisposing cause of lung abscess often contributes prominently to the clinical picture. During the development of an abscess, the clinical findings are indistinguishable from those of severe acute bronchopneumonia. The patient usually has fever, chills, pleuritic chest pain, and prostration. Sputum production may initially be minimal but can become putrid or fetid. This strongly suggests the diagnosis. Hemoptysis occasionally precedes the onset of productive cough. Physical findings may be undistinguishable from those of the pneumonia. Laboratory findings. Leukocytosis is present. Imaging studies. Chest X-ray initially shows only collapse or consolidation. If a solid or dense infiltrate is present, the diagnosis of carcinoma or tuberculosis may be suggested. Air fluids levels develop once bronchial communication is established. Differential diagnosis. An abscess differs from bronchiectasis in that in the abscess the infection is extrabronchial. The most common condition causing abscess of the lung are tuberculosis, fungal infections, and carcinoma. Since carcinoma underlies 10–20% of lung abscesses, this should also All should always be excluded. Bronchoscopy, sputum, cytologic examination, and close follow-up are essential. The X-ray appearance may resemble lung cyst or blebs. Complications. The complication of lung abscess, see here come written, it's this picture here, abscess. The complication of lung abscess are local spread causing loss of additional parenchyma or even loss of an entire lobe. Hemorrhage into the abscess, which can be massive, bronchopleural fistula, and emphysema, tension pneumothorax, pneumothorax, and pericarditis. Metastatic abscesses may occur, especially to the brain. Failure to heal. The most common complication requires resection. Late complications are residual bronchiectasis, chronic abscess, chronic bronchopleural fistula, and recurrent pneumonitis. Treatment. General measures. Treatment of patient with lung abscess involves the general immediate resuscitative measures necessary for a patient in profound sepsis, including rehydration and control of fever. Sputum should be sent immediately for culture for aerobic and anaerobic organisms. Examinations of stains, smears of sputum or tracheal aspirate scans suggest appropriate antibiotic therapy. Bronchoscopy may be repeated at regular intervals to maintain drainage. Surgical treatment. Occasionally, external closed drainage may be considered in severely ill patients with acute disease who are poor operative risk, have persistent sepsis because of inadequate bronchial drainage. Fewer than 5% of patients require surgical therapy unless an underlying carcinoma exists. As long as improvement occurs on medical therapy, surgery is unnecessary. Rarely, emergency lobectomy may be required for massive hemoptysis, as in patients with Rasmussen aneurysm secondary to tuberculosis and lung surgical interventions. Bronchopleural fistula, pneumothorax, pneumothorax, metastatic cerebral abscess, sepsis, fibrosis, bronchiectasis, amyloidosis. Lung cancer. Lung cancer typically manifests itself in the 6th decade. Smoking is the cause of 80% of cases, but asbestos exposure and atmospheric pollutants are also implicated. The patient who is at high risk for lung cancer started smoking at age 25 or before, smoked a pack a day for 20 years, is over age 50. The highest risk is in a smoker working and or near asbestos. Lung cancer is a lethal disease. Asymptomatic patients have the best prognosis since once symptoms occurs, 75% of patients are incurable. Those who have had symptoms for less than 3 months have a better prognosis than those with symptoms of longer duration. Once lung cancer is diagnosed, mean survival is 9 months. Of patients diagnosed with lung cancer, only 20% survive 1 year and 8% survive 5 years. Pathologic features. Squamous cell carcinoma. The major pathologic features of squamous cell carcinoma are keratinization, cellular stratification, and intercellular breaches. Squamous cell carcinomas account for about 30% of all cases of lung cancer. 2/3 are located centrally near the ileum and 1/3 peripherically. The growth rates and the rate of metastasis tend to be slower than that of other lung tumors. Adenocarcinoma. Adenocarcinomatous, which constitutes 30% of lung cancer, are characterized as acinar, papillar, and bronchoalveolar. Acinar adenocarcinoma is composed of glands lined by columnar cells that secrete mucin. Bronchoalveolar carcinoma is characterized by intraluminal papillary fragments that appear in alveoli or small bronchioles. Bronchoalveolar carcinoma is a common scar carcinoma and may be spread by aerosol transmission. This incidence is increasing, perhaps as a consequence of the rise in lung cancer among women. Small cell carcinomas have small, round nuclei with nuclear chromatin and cytoplasm. They are so biologically and clinically distinct from all other cell types that the term non-small cell lung cancer often is applied to all other cell types. Small cell carcinoma comprise 25% of all lung cancers. They occur centrally, metastasize early, and are the most resistant to combined modality treatment. Large cell carcinomas are composed of large polygonal spindle or oval cells arranged in sheets, nests, or clusters. Multinucleated giant cells, intracellular hyaline droplets, glycogen, and acidophilic nuclear inclusions may be present. These tumors are seen peripherally and are less common and less malignant than small cell tumors. Squamous. These tumors show both squamous and adenocarcinomas components. They account for less than 1% of lung cancers. Their behavior is similar to that of adenocarcinoma. Carcinoid. Carcinoid tumors are derived from Kulczycki type cells, are centrally located, and have a vascular stroma. They are sometimes classified as bronchial adenomas, but are truly malignant, so they are slow growing and slow to metastasize. Pulmonary carcinoids rarely produce the carcinoid syndrome. Bronchial gland carcinomas. Bronchial gland carcinomas are of two types: adenoid cystis and mucoepidermoid. Adenoid cyst carcinomas are composed of epithelial cells that form small duct-like structures or large masses with interspersed cystic spaces. These tumors were earlier referred to as cylindromas. They are more aggressive locally and tend to metastasize more than carcinoids or mucoepidermoid carcinomas. The mucoepidermoid carcinomas are rare in the lung and are characterized by the presence of squamous cells, mucus secreting cells and cells of intermediate type. These cells have a much more bland appearance and are less aggressive than those of adenocarcinoma carcinoma. At present, it's common to divide all lung cancer into two subgroups: small cell lung cancer and non-small cell lung cancer. Clinical findings. Are related to the location and malignant potential of the tumors. In 5–10% of patients, no symptoms are present when the lung cancer is first diagnosed. The cancer is usually discovered on chest X-ray or rarely a positive sputum cytologic examination. Most patients have symptoms which may be designated as intrathoracic, extrathoracic, or non-specific. Intrathoracic symptoms. Intrathoracic symptoms may be bronchopulmonary, resulting from irritation or obstruction of a bronchus, and include cough, hemoptysis, wheezing, and pneumonia. Intrathoracic symptoms may be extrapulmonary, resulting from extension of the tumor beyond the confines of the lung. Patients may have pain or pleural effusion due to extension to the pleura or chest wall, hoarseness due to involvement of the recurrent laryngeal nerve, neck or facial swelling due to obstruction of the superior vena cava, diaphragmatic paralysis due to involvement of the phrenic nerve, or pericardial effusion due to direct extension. A tumor in the apex of the lung or superior pulmonary sulcus may cause Pancoast syndrome as a result of involvement of the branchial plexus, the sympathetic ganglia, and the ribs and vertebral bodies. Symptoms are pain, upper arm weakness, and Horner's syndromes, means ptosis, miosis, enophthalmos, and ipsilateral decreased sweating. Squamous cell carcinoma is the most frequent cause of a Pancoast tumor. Extrathoracic symptoms. May be due to metastatic or non-metastatic causes. The commonest sites of metastasis in decreasing order of frequency are the liver, adrenal glands, brain, skeleton, and kidney. Extrathoracic non-metastatic symptoms are caused by the secretion of endocrine or endocrine-like substances by the tumor. These paraneoplastic syndromes are classified as 1. Metabolic Cushing syndrome, excessive antidiuretic hormone, hypercalcemia, ectopic gonadotropin. 2. Neuromuscular carcinomyopathy, peripheral neuropathy, subacute cerebellar degeneration, Eaton-Lambert myasthenic syndrome, polymyositis, encephalomyelopathy. 3rd one, skeletal. It's clubbing, hypertrophic pulmonary osteoarthropy. 4th, dermatologic acanthosis, nigricans, scleroderma, dermatomyositis. 5th, vascular. It's migratory thrombophlebitis, non-bacterial verrucal endocarditis, arterial thrombosis. And 6. Hematologic anemia, fibrinolytic purpura, non-specific leukocytosis, and polycythemia. Hypercalcemia due to parathyroid hormone-like substance is most often associated with squamous cell carcinoma. Other paraneoplastic syndromes are most often associated with adenocarcinoma or small cell carcinoma. Non-specific symptoms. Non-specific symptoms such as weight loss, anorexia, weakness, lassitude, and malaise may occur without other symptoms. In 10% of patients, these symptoms prompt the visit to a physician. Diagnosis. Lung cancer is most often suspected when an abnormal chest X-ray is observed in patients presenting with symptoms or for a routine physical examination. The radiographic abnormalities are classified as hilar, pulmonary parenchymal, and intrathoracic extrapulmonary. The radiographic findings are often characteristic of the cell type. Approximately 1/3 of squamous cell cancers presents as a peripheral mass, 2/3 of which are greater than 4 cm. Cavitation and obstructive pneumonitis are more common than in other cancers. Adenocarcinomas and large cell tumors present most often in the periphery, large cell tumors, and have a lesser incidence of hilar abnormality than squamous or small cell lung cancer. Small cell tumors appear primarily as hilar masses. Also, chest X-ray remains the best method of detecting lung cancer, and also as a symptomatic patient who has a lung cancer discovered on routine chest X-ray has the best prognosis. Several trials of routine chest X-ray screening for early detection of lung cancer have failed to demonstrate improved long-term survival. Once a patient in the high-risk group is shown to have an abnormal chest X-ray, the primary objective should be to establish the diagnosis of lung cancer. Flexible. Fiber optic bronchoscopy with biopsy or brushing, or fine needle aspiration with fluoroscopic or computed tomographic guidance can establish the diagnosis in over 90% of cases. Mediastinoscopy for biopsy of hilar nodes of mediastinotomy for aortopulmonary nodes may be necessary. At present, it is rare to have to resort to exploratory thoracotomy to establish a histologic diagnosis. Treatment. Surgery. The surgical procedure has as its primary goal removal of the tumor and all involved lymph nodes. This is accomplished by lobectomy, bilobectomy on the right side, or pneumonectomy. In older patients or in patients with marginal pulmonary reserve, a segmental or wedge resection may be carried out. A secondary goal of the surgical procedure is to provide accurate anatomic staging. Radiation therapy. Radiation therapy in lung cancer is employed for palliation of unresectable tumors as adjuvant therapy in combination with surgery, and rarely for cure in medically unoperable patients. Curative radiation therapy in this latter group has a 5-year survival rate of 16%. Routine preoperative radiation therapy has been shown to provide no survival benefit. Preoperative radiation improves survival in patients with small cell lung cancers and pancreas tumors. Postoperative radiation therapy decreases the rates of local recurrence but doesn't affect distant recurrence of surgery. Chemotherapy. Numerous trials of a single drug postoperative chemotherapy have failed to show any benefit. The lung cancer study group has shown that it completely resected stage 2 and stage 3A non-small cell lung cancer postoperative chemotherapy with cyclophosphamide, doxorubicin, and cisplatin results in fewer recurrences, delay in time to recurrence, and improved survival. Neoadjuvant therapy. There is currently interest in employing preoperative chemoradiotherapy in stage 3 and small cell lung cancer in order to improve resectability. Tumor response has allowed for potentially curative resections, but the impact of the modality on long-term survival of large numbers of patients remains to be documented. Brachytherapy. Brachytherapy is the operative implantation of radioactive seeds of iodine-125 directly into the tumor's mass and the installations of the iridium-192 into mediastinal catheters postoperatively. Using these techniques, the 5-year survival rates of medically unresectable patients with stage 1 and stage 2 lung cancer in 38%. Brachytherapy may also be used for palliation. Secondary malignant neoplasms of the lung. Lung metastases occur in about 30% of all patients with cancer. Depending upon the primary lesions, the number of metastases may be limited, and a few of these patients may be surgically curable. The most frequent sources of solitary metastatic lesions are the colon, kidneys, uterus, and ovaries, testes, malignant melanoma, pharynx, and bone. In colon lesions, solitary metastasis is the ultimate diagnosis in about 5%. 10% of malignant colon lesions are solitary metastasis, and in 90% of these cases, a history of the primary is available. Certain criteria for selection of patients suitable for resection have been developed. 1. The initial primary must be controlled and no other metastasis can be present. Second, when the initial primary is a squamous cell tumor, the lung lesion should be evaluated as a new primary. Third, when the initial lesion is an adenocarcinoma, other common sites of metastasis must be sought. Fourth, a waiting period of 3 to 6 months is advisable before thoracotomy if the primary lesion was treated within 2 years. Fifth, CT scan of the lung must be obtained to rule out additional metastasis. Sixth, synchronous appearance of a pulmonary metastasis and the primary lesions must be evaluated individually, but in general the prognosis improves as the interval between control of the primary and the appearance of the lung metastasis increases. Seventh, multiple lesions, particularly when the bilateral or involving different lobes, usually indicate a poor prognosis. However, multiple resections for metastasis from osteogenic sarcoma have been shown to be worthwhile. About 80% of solitary metastases meeting the above criteria are found to be resectable. 80% are carcinomas and 20% are sarcomas. The 5-year survival rates following removal of the carcinomas is 35%, for the sarcomas 25%. However, multiple repeated resections may be effective. Only a few 5-year survivals following removal of lung cancer metastatic from malignant melanoma or the breast have been reported. Thank you very much for your attention.